please. Okay, Jack,
Okay.
we are ready to go.
Okay, great. Well, welcome to everyone. Thank you for finding time in these busy times. This is our next to last meeting. I'm reminded that our final meeting is late next month. So I want to welcome everybody to the October Cost Growth Implementation Committee meeting, and let's call the meeting to order. I think we want to do some introductions, don't we, Sarah, first, to make sure we know who's on the line and all that. Do you want to, since you probably see everybody because you're so skilled, do you want to do that?
I can. Okay, Jack Friedman.
Here.
Kevin Iwachina.
Here.
Patrick Allen. Craig Anderson.
Present.
Catherine Correa.
Present.
Angela Downing.
I'm here. Thank you.
Bill Ely.
Here.
Jessica Gomez. Mary Beth Guarino. Melissa Higgins said she's running a few minutes late. Jason Hawkins. Brian Kelly.
Here.
John McConnell has a conflict, maybe joining us at 10 if he can. Mark McMullen. William Olson.
Here.
Ken Provencher.
I'm here.
Shannon Saldivar.
Here.
Scott Schellenberger.
Here.
And Andrew Stolfi. Okay, we've got critical mass.
Good. All right. Well, again, welcome to everyone, and thank you for your time this morning. Let's do we want to well, let's do this. Has everybody had a chance to look at the July minutes? And are there any questions or clarifications, any confusion? I don't think we typically don't do a motion to accept these, do we, Sarah?
Nope, just any corrections or clarifications.
Yeah, right. Anybody want to make any edits, or we're good to go? Okay, hearing none, I think we will move on. Let's take a look at the agenda today. We have a 2-hour meeting, which includes public comment toward the very end. But in general, what today is about is hearing from Jeremy and Sarah about, generally how the implementation work is going. We're going to get a good update on the value-based payment compact work that's been underway for some time now. And then just sort of generally, get up to date on how implementation is rolling out as we get, we get into our first year of measurement. And then we're also going to spend some time looking at some initial cost growth data. We're going to look at, you probably have seen some of that. It was in the material that was sent out the other day. I found some of it a little confusing, actually. So I'm looking forward to some good dialogue on this. And then we're also going to talk about the initial public hearing. And there have been folks on this council that have been working on that. And that's coming up relatively soon. We want to talk about how we're going to begin to roll this work out for the public to understand it, to comment on it, et cetera, et cetera. And then that's really the bulk of it. We'll have a public comment for anybody who wants to say anything, and we will wrap up and talk about what's in store for our next meeting. So that's generally what we're looking at. With that, I'm going to ask Jeremy and Sarah then to lead us through some of the updates that have been happening, please.
Okay, thanks, Jack. I think I have the first set of updates. Next slide, please. So we've had some questions come in from the public, from various payers and provider organizations about implementation timing, and whether or not implementation of the cost growth target program might need to be delayed or postponed because of COVID. We thought it would be helpful to spend a few minutes today talking about the phased in implementation for the program that you as the implementation committee had already recommended and the timeline that we established last year and earlier this year. So just the next couple slides are just going to remind everyone of the timeline we're on and what pieces are coming together when. So 2021, calendar year 2021 is the first year of measuring healthcare cost growth in Oregon. That is, we'll be looking at cost growth between 2020 and 2021 and comparing that growth to the 3.4% cost growth target. And implementation is phased in. So next slide, please. What are we doing this year while we wait for calendar 2021 to complete? We are collecting historic cost trend data. We're collecting the data for 18, 19, and 20. We are collecting that data right now. We asked the payers for their initial data submission on October 1st. We'll talk more about where we are with the data submission in a couple of slides, but essentially we're going to be spending the rest of the quarter working on that data collection. We're hoping to report out on that historic 18, 19, and 20 data in the first half of 2022. We'll see how long validation takes. We'll see what state the data are in and when we're ready to report that. So a little bit fuzzy on the timing, but we are hoping for some reporting next year. And we are not starting by reporting payer or provider organization level data. This 18, 19, and 20 data will be reported at the state and market level only. So Medicaid, Medicare, commercial. And there's no accountability that will be applied. So no performance improvement plans, no financial penalties. None of that kicks in yet. So this is just historic understanding the state of the state in 18, 19, and 20 before the official implementation of the program. Next.
Sarah, there is general appreciation that 20 and 21 are going to be slightly aberrant years because
Absolutely.
of the pandemic. And I don't know whether or not we're looking at more utilization this year than in 20. But both of them are going to be slightly strange given what we've been up against. And that's understood, right?
Absolutely.
Yeah.
And I'll talk more about how we're thinking about that in a second.
Great. Thank you.
So for the first year of the cost growth target, 2021, that will be looking at the data between 2020 and 2021. As I said, as Jack just mentioned, we know these are odd years. The data are almost certainly going to look different. And we will have to think about that. We are going to be collecting that data beginning in September of 2022, and we'll be reporting that data either in late 2022 or early 2023. Sorry, there's a typo on the slide. It should be early 2023. This will be the first time that we report payer and provider organization level data, but no accountability applies yet, just the public reporting and the transparency. So still no performance improvement plans, still no accountability. Next. Then for the second year of the cost growth target program, that's when we'll be looking at cost growth between 2021 and 2022. The data will be collected in fall of 2023. The data will be reported in late 2023, early 2024. Again, payer and provider organization level data will be reported. And this is the first time any accountability mechanisms apply. So this is the first time that performance improvement plans could be required of any payer or provider organizations that exceed the cost growth target with statistical certainty without a good reason. And you might remember a few months ago, we spent quite a bit of time talking about what that accountability process would look like, what a good reason would be, and what are some of those considerations that would be taken into account. And this is where changes due to COVID and what the world looks like on the other side of COVID would be factored in. So next slide. Just to remind everyone of the recommendations that you made on before the accountability applies and the process that we'll be going through. So we will be ensuring statistical confidence. So only payer and provider organizations that exceed the cost growth target with statistical certainty might be held accountable. So we know, especially for smaller organizations, there might be some noise in the data just due to those small numbers, and this step will help mitigate that. Then there'll be a whole process of understanding the reasons for exceeding the target. So these will be individual conversations with the payers and the provider organizations. We'll share findings, we'll identify the key factors that are driving cost growth. We'll look at supplemental data. There'll be a lot of back and forth to understand what actually was going on and why that organization came in above the target. And then there'll be what we're calling determination of reasonableness. And that's the consideration of whether or not those factors meet the criteria that you helped us, that you established in your recommendations. So some of the factors that might be considered good reasons for exceeding the cost growth target include, but are not limited to, changes in mandated benefits, changes in taxes or other administrative factors, changes in federal or state law, new pharmaceuticals or treatments entering the market, acts of God, including pandemics or natural disasters, and investments to improve population health and or address health equity. So this was a list that we all, we refined earlier in developing the committee recommendations. And we went back and forth a little bit. So you might remember the conversation, whether or not this list was too generic, not specific enough, also recognizing that we can't anticipate everything that came up, but this would at least provide some parameters where we look at things that might be reasonably under a payer or provider's control.
Should we just lob out questions as you're going along, Sarah?
Yeah, just about to stop. Go ahead, Brian.
Okay. So where's the accounting for just the crazy cost of our personnel in this? I didn't hear you mention that. So
That would be something that would come up in that probably that middle bucket, understanding the reasons for exceeding the target. And I think if we look at the data and in that back and forth in that conversation, it comes out that really what tipped an organization over the cost growth target was their personnel costs, and those personnel costs were because of a pandemic. That would be one of those rationale, sort of acceptable reasons. I think we are a little bit hesitant at this point to sort of give any definitives and say like, yes, absolutely, this scenario would be a pass, because we really want to make sure this is a data informed process and that we're looking at what the factors were for each individual scenario. But do other committee members, Jeremy, do any of you want to?
Well, I also want to remind folks, this is a transparency only year. So there's no performance improvement plans or other accountability for being above the target, reasonable or not.
And again, we're not even planning on reporting payer and provider organization level performance publicly in this initial data collection.
But I do think that, that we wholly expect issues like what's happened with personnel, especially with Delta. I mean, we wholly expect those are going to be the types of things we're going to hear from folks. And frankly, exactly the purpose of this program, to be able to really have that forum and venue for folks to say what are the challenges in the system and the reasons why.
Okay, let me move to the next slide, please. So we also talked a few months ago as a committee about our plans for provider outreach. We know that there are a number of provider organizations that may not be fully aware of the cost growth target program, when it applies, when it starts, what it means for them. And we really wanted to make sure there was a broad plan and a timeline for doing that outreach and that education. With Delta surging, we heard from a number of you and from partners asking us to pause provider outreach for several months to leave some space and time for the health system to address COVID and the Delta surge. We heard that. We canceled a number of planned outreach opportunities, and we have not yet restarted those conversations with associations and other partners. I think cases appear to be going down for several weeks, and I think we're getting closer to a time where we'll revisit whether or not it's time to restart the provider outreach. We're also getting close to the end of the year. We might want to wait until next year to start this up, sort of wait for after the winter holidays, but then come back to that plan that we originally looked at in July, and making sure that we do have a plan to engage provider organizations around the state and make sure that they're aware of this program, what it means for them, how it works, and what their opportunities are for connecting.
Please don't tempt fate with references to case numbers.
Sorry, Pat. Any other comments or feedback on the timing or the provider outreach?
Any comments, folks? I think this is well thought out.
Okay, well, let's keep going. Give you an update on the data submission. So this was something we spent a good chunk of the year working on with all of the payers who are the data submitters, with our technical work group. We published the data submission template and guidance on June 30th. We held a training for all of the data submitters in August. We held open office hours throughout the summer and provided a lot of individual technical assistance with the data submitters. And the initial data submission, again, that 2018, 19, and 20 data was due October 1st. Next slide. So with that, as of last Friday, we have received 50% of the expected data submissions. So we're expecting 36 data submissions from payers. That's not necessarily 36 different payers. Some payers have multiple submissions based on how their lines of business are organized, but we're expecting 36 files. We have 18 in-house. 5 of them need to be resubmitted. We're doing a pretty deep multi-stage validation of all of these data files, and we've identified a couple of files that need to be resubmitted. And that is completely expected, especially for the first year in this program. We've heard from some of the other cost growth target states that are a few years ahead of us. They go through multiple resubmissions with some of their data submitters. This is an iterative process, and this is brand new for some submitters, and so completely normal parameters. We also, the other half of our data files are expected. We've talked to 16 of the 18 file owners, file preparers, and they have an extension that's been granted or some deadline. And there were a number of factors that influenced that. So some folks have needed additional time to work through the logistics, transferring data from one side of their house to another, especially for those organizations that have multiple lines of business or that need to coordinate because of how their contracts are set up to get all of the data in the right place to actually build the file. Some data submitters just needed a little extra time, and we thought that it was really important to make sure we're getting this initial submission right and that it's worth taking a little extra time for collecting that data. We're also working through the validation process. All of the data submitters that we're working with so far have been incredibly responsive, and we're really appreciative of all of their time and their staff and the back and forth that we've been having. A lot of the questions that we have, things that look weird, some of them are very easy things to clean up, and some of them require a little bit of a deeper look. So we're going to continue to work through that over the next couple of months. Any questions about the data submission or validation? I would also say, and Michael, maybe you have some comments to add here, 36 data submissions is a lot. The other cost growth target states do not have anywhere near this many. And we were a little worried about how what this process would look like. And so we're really pleased at how well it's been going so far. I think to have 5, 6, 7 data submissions, and that's a little easier possibly to manage, but just wanted to call that out.
I will confirm, Sarah, that you have been most brave.
You'll have all of the data to play with. So, okay, let's talk about the new advisory committee. So you are hopefully all tracking because I've emailed you about this a couple of times. The implementation committee is sunsetting at the end of this year. So after this meeting and the November meeting, and we are standing up the new cost growth target advisory committee. You all previously provided some feedback on the charter, in the membership, the proposed composition of this new committee. So we opened recruitment for the new advisory committee in mid-September. Applications were due on Friday. So we've just closed that application process, at least temporarily, and we'll be bringing proposed members to the Oregon Health Policy Board for their discussion and review next week. So we'll see what the policy board thinks about that. It might be that we need some more specific expertise or representation that's not within the current batch of applications. So we might need to do a little bit more recruitment, might need to reach back out to some folks. So we'll see how that conversation with the policy board goes and what the next steps look like after next week's meeting. I think our plan, our timeline is still to have the new advisory committee appointed by the end of the year and be able to start meeting January, February of next year. I think we're still on track for that timing. Any questions about the committee?
Sir, can you just speak to the insertion of the word advisory? I don't think that exists today. So just the intention behind that.
Yeah.
And maybe adding the word, but maybe to speak to that.
I think we were trying to differentiate between the current committee, which is called the Implementation Committee, and was charged with the implementation recommendations. Now that that body of work has wrapped up and we're moving into running the program, we thought that having a body to provide ongoing advice, guidance would be appropriate. I think we just sort of picked that word. I don't know that we thought, I don't know there was anything more deep behind that.
And we're advising OHA.
And the policy board.
And the policy board. Okay, thank you.
We know that there are a couple of decisions that the new advisory committee will be charged with. Most specifically, you as the implementation committee recommended that a future group revisit the value of the cost growth target in a couple of years. And so we know that is one charge of the new advisory committee, but we also anticipate there'll be other things that come up as we work on implementation, other pieces of the program, continuing to think about what cost growth target public hearings look like, what reporting looks like, how the accountability mechanism we roll that out. There are lots of potential pieces that we'll be looking to the committee for some guidance on. Great, Jeremy, I think the next updates are yours.
All right, so quick update on the BuyBased payment work. Just a reminder around the compact and success that we've had in getting folks signed on and committed to that. We've had 47 organizations sign on, not many new additions since the last update. We haven't really been doing additional outreach at this time, but expect that we will be doing more as this work continues, and we'll be inviting more folks to sign on. But I'm still really excited that from a payer side, the signers represent about 3/4 of all of the insured lives in the state. And just a reminder that this is still the biggest commitment we've seen to value-based payment in any state. And it's certainly gotten the attention of our federal partners, who I think have been pretty impressed by it as well. Next slide. The group is now meeting monthly. I think we've had 3 meetings. I have our 4th this week, if my math is right, or memory is right. Here's the overall group. It's a really great, I think, highly energized group. I've had a lot of discussion around centering equity in this work, and that trickled out into some of the recruitments for some additional members. Have a 3-chair co-chair model with Doug Boyson from Samaritan Hospital in Corvallis, Elizabeth Powers from Winding Waters and FQHC up in Northeast Oregon, and Ken is from Pacific Source. And Ken, feel free to jump in here with any additional details. Next slide. The group overall is charged with really ensuring that the compact is successful, and identifying ways that we can collectively make sure that we're successful in our movement from fee-for-service to value-based payment. The group's charged with coming up with a roadmap for implementation as sort of step 1, and step 2, beginning to look at barriers to adoption of value-based payment, and recommendations for how we could address those barriers. And then we'll move into to ongoing monitoring and reporting on progress, as well as any other recommendations for whether the targets are reasonable or need to be adjusted. Next slide. They're just beginning to start to think about the barrier work. I think probably not a surprise. I think the thing that's probably on most folks' mind is just the pandemic overall, and sort of this tough spot to be in, especially as Delta hit, of everybody being pretty tied up the last couple of months and pretty exhausted, and at the same time that kind of hit at probably a window to really be advancing this work for next year. So at an upcoming Oregon Health Leadership Council meeting, I know we're going to be getting some feedback on just sort of capacity right now, to see if that helps inform where we need to lean in or adjust going forward. But the group overall, broadly, sort of COVID aside, we'll be looking at variety of other types of barriers and ways to tackle those. So example, that is just sort of the ongoing capacity or need for really for a culture change at the provider level, and we'll be making recommendations around things like technical assistance or readiness tools, things like sample VBP contract language or elements that would really help providers as they're thinking about what is a VBP that really meets the compact goals. Another example that's come up is repeatedly among this group, as well as within the VBP work group, is issues of making sure folks are connected to primary care providers and the importance of having a primary care provider relationship for being able to not just do attribution for total cost of care, but also for how you actually align a value-based payment model that's based off of population health. So those are the types of issues that we expect to start to wade into in the coming months. Ken, anything you would add or any questions from anybody?
No, I think, Jeremy, that's pretty accurate. I think, we're still, I think, assimilating the members that became part of the compact this summer, getting people up to speed, making sure that we have the focus on the role of the compact group versus this group, and then really identifying the things to tackle. What's the right areas of work to move the work along for this group.
Jack, do you have your hand up?
Yeah, I had a question, Jeremy or Ken. In the past, we have talked about the challenge of self-funding and the fact that we have a lot of self-funded business in the commercial market and not as much value-based around that. Has the committee addressed that at all? And are there some paths to overcoming that structural block?
Yeah, not really yet.
Okay.
Yeah, I think everybody's acknowledged it. Acknowledged we've got to figure out how to build some momentum and start to pull in the self-insured market. I mean, I do think PEB is a critical player here. We have almost 100,000 lives and self-insured part of PEB, and I think that's where the state really needs to be able to sort of lead and show by example to some of the rest of the self-insured market.
Yeah, wonderful idea. Looks like Craig has a question.
Yeah, thanks. I'm trying to get a sense for the work group on how you're getting input more broadly on barriers across payers and providers in the state. Is it just how are you gathering that information and getting a sense of that?
I'd really starting to think about communication strategy, like the outreach. I guess they're going to start with that, or leadership council, and getting some feedback.
I can't hear you, and maybe other people can, and it's just me.
What about now?
Yeah, we can hear you now.
Just got all sorts of error messages. I'd say, Craig, this is really just still getting off the ground. So I've started to talk about the need for a broader communication strategy. We'll be starting with that conversation with folks at the Oregon Leadership Council for some initial feedback. But I think we're on the front end of that, and more work to come. All right.
Any other questions or comments from anybody on this topic? Jeremy, that's it. Yeah.
Yeah, I will just add one last piece here. Pat and I've been making rounds with our federal partners and CMS leadership. They're really leaning in on paying for value. CMMI, the Center for Medicare and Medicaid Innovation, came out with their strategic plan last week. There's a lot of references to moving towards total cost of care and value-based payment. They've convened a handful of states over the last few weeks or month to talk about really multi-payer alignment. So we're still kind of waiting to see what's coming out of there, but certainly they're aware of the compact, and we're hopeful that maybe there's an opportunity to bring in Medicare to really help with this work and create some more alignment.
Great. Jeremy, it strikes me that we're into basically November now of 21, which means whatever value-based contracting work was underway for 2022 is probably done by now. So we're probably not going to get an enormous leap into that world in 2022 above where we are today. So my question is it possible to have some of these models and paths to implementation identified by, say, next spring, 2022 spring, second quarter, so that the health plans and the providers can then engage in the negotiation for Jan 1 of 23, so we can make some leaps forward in that world? Is that the thinking?
Yeah, I might let Ken or other folks weigh in here. You know, I don't think we probably have a good read on how much progress we did or didn't make this year. And I think still trying to wrap our arms around the contracting cycle. And does that mean trying to make up for more of it next year, or does that mean needing to make some other adjustments?
Yeah, I think, again, I think the group is probably still trying to get its head around whether what you just described, Jack, is a function of the group, or is a function of the group to really drive towards the levels of value-based payment,
right?
And to really try to address it that way. So I don't know that it's been agreed upon that getting to a model or getting to a couple of models is necessarily the purview of the committee. I think they're working through that.
That makes sense. Okay, thank you for that. All right, other comments or questions on this work? Thank you to all the folks who are leading it, by the way. Yes, Sarah, you had a comment.
Jack, I was going to mention that one of the reports that OHA has is a payment arrangement file report that looks at the different types of payment arrangements relative to the land categories. And if the implementation committee is not hasn't seen that, that dashboard might be of interest, and I can drop the link in the chat.
Great, that's a good idea. Yeah,
Sarah, I do think there was still a little bit of back and forth in making sure that data was completely accurate, just in terms of how submissions were done and how data was interpreted. So,
okay, so preliminary data maybe pending some updates.
okay. Shall we move on to our next topic? Yeah, I'm going to let Jeremy and Sarah take this as well, but just as a reminder, we recall that this committee recommended some time ago that we figure out ways to create transparency, accountability, and knowledge for the folks in our state, so they are aware of what is happening in this space and can get behind it and support it and see the value in it. So in that vein, there's been some work underway to put together our first public hearing about what the committee is doing, what the status of, and what our goals are. And so I'm going to ask Jeremy and Sarah to give you an update on where we are in that, and maybe what roles we might be playing.
Thanks, Jack. We're going to go to the next slide. So just a reminder to folks, the annual cycle that really this program is, as we've said a bunch of times, measuring whether we met the target or not is sort of one day point in time, and the whole rest of the year was really focused on really analyzing the data, analyzing the trends, transparency, and moving into where the opportunities are for addressing costs and working collectively on those throughout the year. Big piece of that transparency piece is both a annual cost trends hearing and as well as an annual report out to the legislature. Why don't we go to the next slide? So the committee, you all recommended earlier, those would be held on an annual basis, would be roughly modeled similar to how they are in Massachusetts, looking probably at 2 days and bringing in a broad group cross-section of healthcare leaders, of consumers and others, and broadly trying to really bring in both executive and legislative branch leaders and really use it as a way to ground everybody in what the data is telling us, but then more importantly, lead into conversations around challenges folks are facing and opportunities to address cost. In this first year, we've been trying to figure out exactly when this first one would be, given a couple of different moving things, obviously COVID and the pandemic, but also getting the first round of data submission and knowing that it would take longer the first year to really validate that. And so other critical piece is that the policy, the Oregon Health Policy Board is really the sort of convener of the hearing, but obviously with advice and input from you all this year and from the future advisory committee. So Sarah talked a little bit more. We've stood up a small planning work group of health policy board members to start to plan for that first hearing. Sarah will get a little bit more in the details, but we have been trying to figure out whether to do it with or without the first year of data, and have really decided that there's a lot of value in getting the first one of these off the ground, especially in light of everything everybody's faced in the health system this last year, but also just making sure we maintain momentum for the program and make sure that we sort of recognize this is going to be a new muscle for us to sort of all exercise, and so want to start and get one going and learn from it and adjust going into the future. So to that vein, are planning to do one early into the next year, and then likely another one at the end of next year, and then get into an annual cycle after that. So Sarah, I'm going to turn it back over to you.
Thanks. So you can see the members of our small planning group here. That group has met twice to provide some initial direction, and we're just going to report back out on where we are with that and collect some additional feedback from you all on direction. Next slide. So as Jeremy said, we originally were going to hold our first cost growth target public hearing in the fall. That did not happen. That plan fell by the wayside. So next slide, our new plan is to hold the initial cost growth target public hearing before the February 2022 legislative session. We are currently planning on a virtual meeting. We're thinking mid to late January, the week of January 17th or 24th. There's a couple of things to schedule around, especially in preparation for the legislative session, but we think that timing feels about right after the winter holidays, but before session. And as we're thinking about this world that we're in and virtual meeting planning, and we were thinking about the different agenda topics we had, it really felt like we had too much content, and trying to do a full day on Zoom was going to be a lot. So our planning group recommends that we are thinking about 2 consecutive days, and those would be shorter sessions, so 2 or 3 hours on each day, back to back, to cover this. Next, we have some objectives for the initial public hearing. So again, as Jeremy said, we were going back and forth on whether or not we should wait for this initial data submission from the payers and use that as the foundation for this initial public hearing, or whether or not there was work and there was value in doing the hearing anyway and using other content. And that's where we've landed. So we think there's one of the objectives is to do the public launch of the program and building awareness of the cost containment effort. So all of our provider outreach and education strategy factors in here, as well as general awareness and focus on where there are areas or opportunities for improvement. It also will provide a venue for legislators, partners, and the general public to build some understanding of the pre-COVID cost trends in Oregon and the impact of healthcare costs on marginalized populations. So we know that COVID has changed a lot, and we anticipate that one of the things that we'll think about in the public hearing is what does COVID mean in terms of the challenge for meeting the cost growth target in future years. But before we can really have that conversation, we have to understand the landscape of where we were and where we've been and what was trending and what were the concerns in Oregon before COVID, so that we can understand the full impacts of COVID and what that means for future efforts to meet the cost growth target. So our proposed agenda outline, the first day would be the longer day. We would provide some grounding to the program. So why are we focusing on addressing healthcare costs? And we heard from our planning group that it would be really great and important to ground this in stories, consumer experiences, and focusing on that as the entry point rather than sort of a data dump. We'd provide some information about the cost growth target program, how it works, why we're doing this. We'd present a little bit of data highlights, some of the 2013 to 19, again, that historic trends that we're going to talk about later in the meeting today. And then we'd have panel discussions. So we do the first panel discussion on the first day, and then we do additional panel discussions on the second day. Those panel discussions would be grounded in the stories. So for example, if we focus consumer stories on, say, pharmaceutical costs, we might do a panel on pharmaceutical costs and let it build from there. We're thinking those panels, this is where we take some inspiration from Massachusetts in terms of having a mix of players. That might be some industry, some delivery system folks, others, and that would be a moderated discussion talking about what the factors are, what's going on in that particular topic. We're thinking that it would be good to do 2 of those panels that were sort of centered around the data or the consumer story, but that the 3rd panel discussion would be a little more action oriented. So we're holding that as a space for taking action. So what does that mean? What are our opportunities? Not necessarily coming up with a whole new brand new policy agenda, but thinking about where are there some places where we might want to focus more or where there's room for action. We really have been focusing on the VBP Compact and the VBP Compact work group as one of our primary strategies, but we know there will be other strategies that emerge. And this panel discussion is one place where some of that might start to surface. Next slide. So our next steps, we are going to bring that small planning group back together in November. We really want to finalize that date, get it on the calendar, have some save the dates out. We want to continue developing the agenda a little bit further, begin identifying those consumer stories, and begin identifying the potential panelists. So with this as the general structure, let's start fleshing out those 3 sessions, thinking about who we want to hear from, how those conversations might be moderated. We really ground this in the consumer experience because that's why we're doing this work. So I'm going to stop there. Members of the planning group, including Kirsten Isaacson, if you're on the line as well, do any of you have anything else you'd like to add about the work of the planning group thus far?
Hey, Sarah, this is Kevin. The only other thing, did we settle on dates yet, or is that still kind of being planned by this smaller group? I know we were looking at a couple of weeks prior to the start of the 2022 session.
We got as far as weeks. So the week of January 17th or January 24th, but not more specific than that yet.
Yeah, great, thanks.
Lisa.
I have a lot of questions about this, and I think I might be confused about what the purpose of this is. Because I thought the purpose was to provide a venue for like the general public and that to provide input, but it seems like there's like a set of panels where you're choosing people who are going to provide that input. And so I guess I'm a little bit confused about like that the purpose doesn't match the agenda to me. And so if the agenda is to gather input broadly, to hear from people broadly, to hear from consumers broadly, then I would assume that you would sort of set it up more like a public hearing kind of process. Is my first, is sort of like, I think I'm confused on that. So I have a little bit of a disconnect between that. And then the second thing I would like to provide input on is I think that there should be a level of outreach that is planned similarly to how you did outreach to providers to marginalized communities and those who serve them. So there's a whole set of organizations who focus in on specific marginalized communities. And I think that having very targeted outreach and intentional conversations with them, whether they be in the provider set or a different set of folks who work in this or who work or provide support in this arena, social services groups, et cetera. I think there should be a concrete plan around that. And I'd like to see that plan.
Thanks. Completely agree on the outreach plan. But I think coming back to your first point, maybe this is just how we worded the objectives, because I don't think we're thinking about this as an open venue for collecting input and public comment. I think when we're talking about consumer stories, when I'm saying sort of grounded consumer stories, I don't mean as a, let's use this as a 2-day, let's everyone come and share those stories, more as we will use that as the setting the stage for the conversation and grounding in that because of the importance of having that voice there, but but that the focus would be on the panel discussion and thinking about what the drivers are, where the opportunities are, rather than just open collecting input. I did not say that very well. Did that help?
I see what you're saying. So when I read this, publicly launch a program and to continue to build awareness of Oregon's cost containment efforts, I feel like that I feel like that's like providing information to the public, right? That's it. But the second objective is provide a venue for legislative partners and the general public to build a shared understanding. I don't think having a set of panels where people are talked at by a group of pre-chosen people, I think provide a venue for those people to build a shared set of understanding. So I'm not saying that there's not value in what you're doing. I just don't think it meets objective 2. And so so I would say if objective 2 is put together a set of panels that help provide information to a subset of that group, then you should do that. I think it's not going to provide information to the general public. So I guess that's where my disconnect is. Like, you have to make a decision about if that's the right objective or not. That's my feedback
For that.
Yeah, I think that's helpful. This is our first of these, and I think we're still trying to figure out exactly how to structure it, and whether it's more public comment hearing oriented, whether it's more by a panel. So it's helpful feedback, please. I think.
Yeah, thank you for that, Felisa. Guys, when I think about stakeholders and in my very humble opinion, who's the most important stakeholder to really understand this, embrace it, etc., it's doctors. I mean, they have the most influence on total cost of care, I think. So do we have any effort underway to widely spread this, the work that we're doing into the physician community? I don't know if Kevin has any thoughts about that. I mean, I think there are plenty of doctors that know this is sort of going on, but the vast majority of doctors don't, and they've got their heads down, working their tails off. And I just wonder what we're doing to kind of educate them, enlighten them, solicit them, all that. Any thoughts on that?
Yeah, so the Oregon Medical Association has had a few listening sessions about these topics over the last calendar year. They're still planning to do that more. We have other physicians that are on the value-based compact now that will help lead that work. And it's going to be really important to ensure that hospitals' health systems help message that too, only because more than half of the employed physicians, physician assistants, and nurse practitioners in the state are now employed by health systems.
Yeah, great point. That's a great point. So your sense, Kevin, is that there are tangible, meaningful efforts underway to try to do this and educate and galvanize and, inspire, for lack of a better term.
The inspiring part, to be honest with you, would be one of the most difficult things because of our COVID-19 activities. People are feeling pretty burnt out.
Oh yeah, I believe me, I get that. Yeah. Okay. All right. Well, it's good to know that there are some efforts underway. Do you agree that physician education is an important component to the success of this work?
Agree in part. When you look at the healthcare financing in general, physicians do play a part, but it is a component of a much larger system. So while we as physicians are responsible for ordering the tests for patients, getting them into the hospitals, etc., there's a whole other component of just the healthcare cost realm that can't be ignored. And that's what health plans and health systems have to also be a part of that conversation. Yeah. I do want to remind the group that I think there's still a lot of value in resurrecting the low value care report that the Oregon Health Leadership Council and OHA had put together, only because we do spend a lot of money on testing that brings low value to the patients that we serve. And there is an attributable cost to the tune of $53 million over calendar year 2016, 2017, and 2018.
How much was that, Kevin?
$53 million spent on low value care.
Well, million here, million there. Pretty soon you're talking about real money.
Yeah, absolutely.
It used to be $1 billion. Now it's $1 trillion. Now it's $1 trillion.
Felisa has her hand up again.
No.
I really, and maybe I'm feeling a little bit feisty today. My friend Jessie Beeson calls it racial justice guns, where you like pull out your racial justice guns and you're like ready to shoot up the place. So maybe I'm feeling a little bit like that today, but I just want to caution us in all of these conversations and in this process of identifying one stakeholder group who is the most important. I think doctors are super critical to this process and are super critical to our overall health systems. I think hospitals are equitably as critical to our overall health systems. But I want to make sure that all of our work and all of the things that we're doing on every single one of these committees that is related to people's healthcare is center people and the patients at that. And I would go even further to say marginalized communities, because we have left them behind for so long. And over the last 2 years, they have burned the brunt of that. And so I think it's an important conversation to have, and I really don't want to dismiss that we have to engage physicians in a different way, and there's going to be a lot of education. I do think we still have to spend an equitable amount of time and effort engaging those marginalized communities in this as well.
Great. Other comments? Fair enough.
Shannon, and then Craig, I think.
Yeah, Felisa, I agree too. So I feel like my view is the consumer perspective. I work directly with consumers, and I know in the reports that have been produced out of this committee, a lot of focus has been put on consumers, but I haven't felt the conversation has revolved around the consumers and really how they're directly going to benefit from this work. I think it feels a little abstract. And I think too, talking to the general public about this, like average consumers, right? It's hard to see how that's going to impact their costs, right? Like what it costs when they go to the doctor or their out-of-pocket maximum. So I've kind of struggled to draw that comparison, but like Felisa said, they're the ones that we're doing this work for, right? Is the end consumer. So thank you for bringing that up, Felisa, and I echo what you've said.
Great.
I would just add again, Felisa, thank you for the comments. I think this is sort of exactly why we thought it was important that we get the first one of these off the ground and not wait a year, and that it was so important that we set the right tone and the right and structure this in the right way. So thank you.
I had one other question, if I could, and I wonder, this Choosing Wisely program that was rolled out many years ago, where the effort is to try to educate both physicians and consumers about making wise choices to eliminate wasteful use. Has that been embraced in any way in any of this work? Is that a vehicle that we might consider for spreading the gospel on using the system wisely?
Jack, I can quickly say that a lot of the elements in the Choosing Wisely initiatives actually showed up in the low value care report. So there's a lot of alignment there.
Yeah.
I think the true challenge is once there's a national effort of publication for initiatives that we shouldn't be doing today in medicine, it's all in the operationalizing of that, specifically with the electronic medical record. How do you build your order sets so that it is disadvantageous to order certain tests? We've at the Oregon Health Leadership Council Evidence-Based Best Practices Committee, we've had the discussion of the low value care report and the Choosing Wisely initiatives. And this is the theme that is consistently brought up. We all know what those initiatives are, but the operationalizing it from a system perspective is the most, most frustrating component, just because there's so many different types of processes that need to be changed.
Yeah, that's great point. Thank you so much. Looks like Craig has a question.
That's a comment really, and it picks up on the consumer theme. And it's something that's made me uncomfortable in doing this work from the beginning. And that is a lot of what we're trying to do with the target cost growth program is on a population level. So we can be successful at a carrier level, at a provider level, and across the market, but there'll be individual consumers within a population that'll have their own experience. So as an example, they could age up and pay a higher premium than the 3.4% cost growth target. They could be on a high deductible plan and have expenses in an upcoming year that affects them personally. So it's when I see the agenda and we talk about stories are anecdotes, and I'm trying to figure out how best to educate the public about what the work we're doing here to try to manage costs at an aggregate level, but still address individual consumers' experiences. And it's just, I'm just not sure how to reconcile that.
I do think this is helpful for us to get some input on. I mean, I think trying to figure out who the primary audience is here, especially for this first one, and are we trying to use it to educate the industry of what's coming? Or are we trying to really bring in those consumer voices? I think that is a thing we're grappling with. So I think this is good input and would welcome some more.
Okay, other thoughts in this area before we move on to our cost data? How are we doing on time, Sarah?
I think we can spend a few more minutes here. I'd really like to just reiterate what Jeremy said. I think when we look at the Massachusetts cost growth target public hearing as our example that we were modeling off of, I think, and maybe some of you have feelings on this, I would say their audience is not the general public. It's not the consumers. It's policymakers, it's industry, it's maybe, to Craig's point, it's focused on that population level. How is this program going? And I think I would really welcome guidance from the committee today. Should we plan on our initial public hearing being focused on a consumer general public audience, or on a policymaker, legislative, industry, or some combination audience? Because those are two really different agendas. I think they're both important. I think we can have engagement plans and outreach plans either way, but I think in terms of actually shaping the agenda, we might need to pick one and structure accordingly.
If I were to pick, I feel like I would pick the sort of the industry provider side of things. So maybe divide it into two pieces, the insurance side, maybe large providers, maybe small providers. And then I think I really would also, I just want to encourage us, like, I think there are a whole host of providers and insurance groups who are specifically working with marginalized communities. And so I would encourage to do much more direct, deeper outreach to those groups than maybe sort of a broad sweeping. We'll invite everybody, and whoever comes, that is not the equitable way to do things. So, and then I feel like really digging in on, and I think that's why I feel like changing that first objective. But I still think the panels that are focused around the consumer experience, like why this work is so critical, like establishing the why for that group, because I think sometimes we can get lost in the numbers, we can get lost in the data, we can get lost in all of that. And most people who come into this work are here for the consumer or for their patients, especially providers. And so since we're asking them to do something different, it's really important to talk to them about why we're asking them to do something different.
So thank you for that, please. I don't know that is necessarily different than what I had in my head. I think maybe it's just a disconnect between the agenda outline and the objectives as stated. Can we go back to the agenda shell slide, Michelle, please? Because I think when we're thinking about that importance of addressing healthcare cost stories, that could be a panel, or it could be a series of consumers telling their story, and that really this grounds why we're doing this. Here's the impact on people. Here's why this is important. I think one of our planning group members suggested that some of those could be recorded in advance, there were some concerns about confidentiality and sensitivity towards sharing those stories, but that really sets the stage for the day. And I think, Felisa, that's what I was hearing you say just now, that it's not necessarily that all three of the panels later are all consumer panels, but that we're starting the day out, we're starting this event out by grounding in the why we're doing this. And then we move to focusing on, okay, here's what this means for payers, for providers. Here are the opportunities for potentially taking action. Here's what we know about the data, but it always comes back and is grounded in the consumer stories that we started off with about why we're doing this program in the first place, because it is a population level program. It is a wonky program, but we start with the why.
I think that's exactly right. And I think where the disconnect is that second objective. So just editing that second objective to match the agenda, I think is great. I don't know, I'm chatting a lot. I don't have stuff to add.
Greg?
Yeah, I just getting back to the stories, getting back to my uncomfortable feeling here is that you could have a consumer story that the work we're doing may not address that specific story. I think that has to be carefully crafted in a sense. There's just particular story could be about, I don't know what it could be. They, like I said, had a high deductible or something like that. And so we're bending the cost curve, but there's still that we're not addressing that specific issue for that consumer with this work. I think we just have to be careful about that, not setting an expectation that we can't meet.
Other comments, feedback from committee members? This is really helpful.
This is Angela. I share some of Craig's concerns, but I think which stories we bring forward, Craig, may help in putting the focus on not their out-of-pocket amounts necessarily, for example, but rather value-based process. So I think we have to be thoughtful on the stories that we bring forward.
Lisa?
Sorry, I think I'm confused again. I feel like the panel, the purpose of that is not to solve, I don't think you're going to solve anybody who's on the panel's problem. So I think that's what Craig, and I think maybe Angela, is that what I'm hearing? Like, you don't want to bring stories forward where you feel like the goal of the program is to solve the problem. I think maybe that panel is to illustrate what some of the problems have been, right? We're bending the cost curve growth because healthcare costs too much, and it costs too much for consumers, but not necessarily like we're going to solve like your one specific issue, right? So am I hearing you right there?
Yeah, you've got it, Felisa.
And I think that's, Felisa, I think how you framed it is how we were thinking about it. I don't think we're trying to think about stories that would sort of frame the very specific policy thing that we're trying to solve, but more like really just set the tone for the importance of the overall program and making sure that we've got that consumer focus at the outset.
Other thoughts from committee members? Folks we haven't heard from yet, maybe?
Anything else, folks? Good dialogue.
I would.
What are next steps there now, Sarah?
Yeah, so the planning group, the small group with committee members and policy board members will meet again in November and continue to work on the agenda. I think given this conversation, I would love to broaden the invite. If any committee members who are not part of that planning group who would like to be, please let me know and we'll add you. This is helpful feedback. We'll come back to you at the November meeting with an update on where we are with the agenda planning for the public hearing.
Okay, are we ready to dive into the cost data? Right, and this will be, I think, an interesting. Sarah, this is just informational. We're not trying to draw any conclusions, or this is just a chance to look at what we have found. It's early data. It's unique. We'll talk about that. I was surprised by a couple of things I saw here. So more to come on that, but let's get into it. I think, are you going to take us through this? You and Jeremy? Yeah.
Yep.
By the way, if Michael is still on,
Michael had to drop off.
Michael had to drop off. Okay, I was going to say it would be good to get his view on how he thinks this might compare to other states he's monitoring, but let's save that for another day. Okay, so let's go through the data and see what questions arise. Okay.
Great. Jeremy, do you want to provide any opening, or do you want me to jump right in?
Well, I just there was while we don't have the data yet on what the 18 to 20 and then eventually 21 official total cost of care data looks like. Sarah and the team have been doing a tremendous amount of work behind the scenes to look at the data we already have through the all payer claims database, and we've looked at a couple of pretty well-known national reports that have been run over the last several years, and have worked with those organizations to let us replicate similar types of analysis with our all payer claims database. And so what Sarah is going to show here is a price utilization analysis. There's a broader report behind this. This is somewhat analogous to annual report that the Healthcare Cost Institute puts out that looks at a variety of utilization and price changes. And the purpose of this really was a couple fold. One, to look at to really just get an understanding. We look at these national numbers that will have Oregon specific data, but usually it's a very small subset of claims within Oregon because they're usually looking at national carriers, and we don't have as much of a national carrier presence in Oregon. So we really wanted to know how this looked at a broader claims set, and looking at the entire all payer claims database, and just be able to see if that stacks up or doesn't stack up to what we've seen in some of the national trends, and really have a better understanding. The second piece, I think, is really to demonstrate the power of the all payer claims database, and really moving into a place where we're doing deeper, broader analysis. And the report that we have here is, I think, the broadest sort of price utilization report that we've seen the state do with all payer claims database. You're only getting some snapshots today, but there's a broader report behind it. We also, it's not in today's materials, but have also looked at hospital pricing, inpatient, outpatient. And again, there's been a bunch of national reports on that have highlighted Oregon, and we wanted to see how accurate those were or weren't accurate compared with when we looked at a broader swath of claims, just to give us a better, more robust understanding. Again, these are only snapshots. Eventually we're going to be talking about total cost of care. And so again, these are only snapshots of what's happening within different parts of the health system, but want to demonstrate the types of analysis that we can start doing and intend to do more of. So back to you, Sarah.
Thanks. So as Jeremy was setting the stage for, this is historic data. This is looking at trends in Oregon pre-COVID. We really want to understand what was driving, what the world looked like, and what we know. So back to our annual program cycle, just to ground in where we are in that process. This is the analyze bucket. We want to make sure that we're building the ability and the capacity to dig in and understand what's going on, and that we understand the cost growth drivers. Let's go ahead one more slide, please, Michelle. So I just want to re-emphasize this because this is a pretty critical difference. When we set up the cost growth target program, we are doing all of this work using two primary sources of data. So the first is the data submissions that the payers will be providing, and that's that data submission that I was updating you on earlier in the meeting. That's how we'll be measuring performance relative to the cost growth target of 3.4%. That's where all of the accountability and all of that is tied to that data set. Then we have all of this additional supplemental deep dive ad hoc analysis that we can do using the all payer claims database and other data sources. everything that we're going to talk about today, everything in the slides, everything in the report, this is all coming from APAC. It is not coming from the payer data submissions. And there's lots of really wonky methodology differences and interesting things about what's in and what's out that we can talk about. But I just want to be really clear that this is APAC data, and that when we start reporting using the payer data submissions, that data will include different things. So, okay. And then just a little bit more on the report and development. So I'm going to preview a couple of graphs from this report that our team has been working on this year. We're looking at 2013 to 19 data using claims data only. So none of the data that we're about to show include non-claims based payments. It doesn't include admin, a number of other things that can be rolled into total healthcare expenditures. So just what we see in claims. As Jeremy said, this is inspired by the Healthcare Costs Institute and their annual report. We've got some trends that we're going to show you. We're also working on a dashboard that will be available online before the end of the year, hopefully, that will let people drill down into these trends to see if it's price that's driving things or if it's utilization that's driving the cost growth. So looking forward to providing a lot more of this data in interactive form, but today just going to provide some snapshots and screenshots at a high level for discussion and initial reactions. Okay. Let's jump in. So just starting with the Oregon and the national trends. So since 2013, per person healthcare costs have increased about 47% in Oregon compared to about 28% nationally. I do want to note that we're not exactly comparing apples to apples here. The blue line, the Oregon data, this is our all payer claims data. The national trend line does include self-insured data, which are not in APAC, as well as admin data. But if we look, if we sort of just look at the trends in percent growth, you can see that Oregon is still experiencing a lot more than national. Some of that jump we see in 2016 to 2017 is driven by Medicare, which we'll see more in the slides in a bit, but there's a lot going on behind this. Next, on average, if we look at per person healthcare costs per year, on average, we're averaging about 5.3% per year in Oregon. So you can think about that 5.3% relative to our 3.4% cost growth target, but that's average over this 6-year period. You can also see there's a lot of volatility year over year, and we're not 100% sure yet what's driving all of this. We want to keep digging in to understand some of these dips and spikes. It's possible growth is volatile. Oregon has a small population relative to national. We're talking, a couple million people in this data, but that's not the couple 100 million people that are in the national data. So some of that is just size and noise in the data. Some of this again is driven by Medicare, which we'll talk about. I keep previewing this. And I also just want to offer that it's possible that there might be some underlying data issues that need to be cleaned up with the all payer claims data submission. APAC has been around for a while, has really strong validation process, but we know from previous experience, from this experience in other states, once these data start being presented in different ways, there might be new errors discovered or things that need to be cleaned up. And so it's possible that there might need to be some corrections that looking at the data in this way will surface those issues.
Sarah, just a quick comment, if I could, and question. We probably know there's been a reduction in the benefits over those 6 years, right? Particularly in the commercial line of business. That is, people are paying more out of pocket in the benefit. That's captured here as well, that higher cost sharing that consumers have experienced as employers have put more on employees to lower their premium costs. Is that captured in this data as well?
This is only the allowed amount on the claims that we see in the all payer claims database. So there's nothing that's been adjusted or taken into account specifically about benefits. But because we are looking at the allowed amount, it would capture the services that were provided regardless of who was paying for them.
So it would be a blend of both out of pocket and
It would be a blend.
And insured.
Yeah.
And we're using the term cost here, but it's probably more accurate to use the term spending, because what we're talking about is health plan payments out to the system at that level. It's the claims level.
Ken has a hand up.
Yeah.
I feel like maybe I'm being thick. How do you reconcile this graph with the previous graph. What's the underlying data in the previous graph?
It's the same. It's the exact same data. The previous graph is just cumulative total growth over time, and this is average annual growth. So the change year over year.
I'm not sure I see those two things connecting that way, but okay.
I have many spreadsheets with the underlying data that I'm happy to share if that would be helpful. It's the compounded growth versus the annual growth, same data. Okay, let's talk a little bit about the overall statewide growth compared to a couple of other economic indicators. Let's go ahead and 2 slides, please. So you have probably seen a similar version of this slide. We've been using some of these economic indicators for comparison in a number of our presentations and talking points for the cost growth target program. So again, we're looking at cumulative growth since 2013. So 2013 sort of starting at 0. Per person healthcare costs in Oregon have gone up 47%. Per person income in Oregon has gone up about 33%. And the average wages in Oregon have gone up about 21%. So same top line message we've had for a couple of years now. No matter how we look at this data, healthcare is growing faster than income and wages in Oregon. The economic indicators here are coming from the Oregon Economic Analysis May 21 economic forecast. And then comparing to some national indicators or indicators of inflation. Again, we have that per person healthcare costs, compounded annual cumulative growth since 2013 compared to inflation, and then specifically to medical inflation. So this is some national data from Fred. We pulled it down in August, and this is the consumer price index for all urban consumers. And there's sort of a specific basket that they report on for medical goods and services. And you can see, again, in Oregon, per person healthcare costs are growing much faster than inflation. Any questions or comments about these 2 indicators?
Just to say something, because it won't make up for the difference, but in the end too, it's the yield, you know, as there's a higher cost share with patients and that's shifted to the collection to the provider to get the actual net is different than the allowed, right? So you have the published allowed off the claim, but the actual net that ultimately is paid to the provider is lower. I'm intuitively confident that it wouldn't make up for the differential that shows there, but I think just as a point, or if you see it differently, happy to hear your thoughts on that.
Anything else before we keep going? William?
No, I was just going to echo that same comment. We've talked about that several times, bringing up the patient assistance and how much that's grown over the same period of time, and how we're not measuring that, which essentially is, you know, is what you're putting on the consumer.
Okay, let's jump into market level trends.
No.
That's how we feel about market level trends.
Right,
Hold on,
right.
Michelle. Go back 1 slide, please. So the last couple of slides we presented were statewide for Oregon, but that can hide a lot of variation by market. We know that the Medicaid, Medicare, and commercially insured populations are really different in terms of their health status, their healthcare needs, and their utilization patterns, and all of those things affect the spending trends. So we're about to break down the data into those 3 markets and compare it to statewide. So next slide. This is that same cumulative growth. So the blue line here is the statewide, that 47% cumulative growth since 2013 that we've been looking at in the previous slides. But now we've added 3 more lines to break out commercial, Medicaid, and Medicare. Medicaid is the green line, commercial is the orange line, and Medicare is the red line. So you can see that between 2013 and 14, we have some substantial increases in spending in the commercial and Medicare markets. This is the expansion, the Affordable Care Act, which drove that enrollment in marketplace plans. We also know that during this 2013 to 19 period, there was a lot of growth in spending on retail drugs. So we had the new treatments for hepatitis C. There were also some new drugs introduced for cancer and for multiple sclerosis that factor into some of the Medicaid spending growth. And we know that the Medicaid cumulative per person healthcare costs initially are lagging Medicare and commercial as those new enrollees came on during the Medicaid expansion in 2014. Some of those new enrollees in 2014 were in higher income families because that was the expansion population, and they tended to be a little bit healthier compared to the previously enrolled Medicaid population. But as we get closer to 2019, you can see that Medicaid spending has continued to grow, 17, 18, 19. One of the things that we're looking at in the full report is some of the reasons why that's happened. There have been a lot of changes in the Medicaid benefits. So new services, coverage that has been included. So things like Medicaid adult dental, things like the Reproductive Health Equity Act. Some of that is what's driving some of this Medicaid increase in the later years.
The other thing I would note is provider taxes. So there's some noise in there, but the basic way we had a pretty significant increase in provider taxes to fill revenue holes with the Medicaid. And generally what we do is increase the amount we pay the system and then tax it to get it back. So that sort of creates a artificial increase.
Yeah.
Thanks, Jeremy. So we're going to do the same shift that we just did, looking at statewide, where we went from cumulative growth to annual growth. So same data, looking now at the year-to-year change. So we have the same 4 lines, statewide, commercial, Medicaid, and Medicare, same time period. What you're seeing is the percent change or the growth in each year. And then the little gray box calls out the average annual growth. So we've got a lot of numbers here. But if we look at average annual growth, we can see that Medicare's average annual growth is about twice as high as statewide. Commercial, Medicaid are a little bit lower. But you can also see there's a lot of volatility. We're not sure what's going on in 2016 in Medicare. That is a sizable dip. We've looked a little bit at some of the CMS reporting on Medicare to try to understand what they think is going on, possible explanations. There are some changes in Medicare spending on prescription drugs. There are some changes in eligibility as more of the boomer population becomes Medicare eligible. And then there are some changes in nursing and home health spending that could account for that fluctuation in 15, 16, 17. But that's not exact. Certainly, again, there's a lot going on here. But Medicare growth is, again, growing higher than the commercial and Medicaid when we look at it on that annual average.
You know, Sarah, this is where I'm just completely puzzled by this. You and I chatted about this the other day. I just don't understand this graph on Medicare. It's counterintuitive to everything I've ever seen or understood. And so I kind of wonder whether Ken or anybody on the plan side, you guys track your per member per month and per member per year spending in your MA product, which has to mirror a lot of this. And I'm just wondering if you've seen this kind of variation in your monthly or annual spending per capita in Medicare Advantage from these years. I have to admit, I stopped looking at these data about 5 years ago, but it's just wildly strange to me. So that's my editorial comment, is just somebody who's kind of an observer now. Comments or thoughts?
I mean, I would say it's puzzling.
Yeah.
You pointed to the decrease, Sarah. I look at those 2 spikes and I don't really understand them. And I don't understand Medicare relative to commercial in particular overall. So there's something there that doesn't feel right. I couldn't tell you what it is, but it just doesn't look right.
Bill?
Bill, is Bill on the phone? Would Bill have any Bill, you're the actuary, for Christ's sake, you and Craig. I mean, speak up.
I am on the phone and I had my hand raised to comment on it. Not just for Medicare, we aren't seeing this sort of volatility. But as you're combining, carriers, I think there's something with the data. But even ignoring, even assuming that's not the case, I mean, this sort of brings up the question to me from a overall plan of accountability around, the cost benchmarks. It all depends on the year you look at. So, come 2022, 2023, when we, first have the first accountability measures or the discussions around performance improvement plans and all that, if we have a similar year to 2016, we in essence sort of declare victory and move on. If we have a year like 2017, that's going to have a very different ramification. So what I'm trying to figure out is how do we marry the process of addressing that underlying trend, which is not going to be year by year, and match that up with real-time annual actions and reactions and explanation. So as I was saying, the degree of variation surprises me, but the fact that it varies doesn't. So I'm just wondering what sort of implications that has upon our annual conversations that these various, stakeholders and subgroups will have.
Jeremy?
Yeah, I don't know if you had answered it to Bill. Certainly jump if you do. I think this is for Medicare. This is fee for service and MA, right, Sarah? So we get the Medicare claims straight from CMS. So there could be some wonkiness in that as well. The experience with the MA plans may not be exactly the same as what we're seeing in fee for service Medicare. But the other piece of this, I think, is this also highlights the reason why we as a group all landed with the recommendation that the data really start with the insurers, because we were worried if we were using the all payer claims database to measure other folks' total cost of care and that was the accountability, we would be spending an entire year in a validation process, and that it would be faster, frankly, to make sure that the data is coming from the plan. So this gives us a line of sight into what's happening in terms of general trends, which we use the all payer claims database for. But I think just a good reminder that the data that we'd be using to figure out who's above or below the target will be a different data set coming from the insurers that the insurers would validate.
And I want to move us just to the next slide, just to show one more data point before we come back to the discussion. I think in some ways it's easy to get distracted by the volatility of the percent change because that's the year-to-year change and that is what we'll be measuring. But
this is helpful.
If we look at the actual dollar amounts that we're talking about, and again, this is just what we see in the claims for the allowed amount. It does not include admin. There's a whole bunch of other stuff not included here. But if we look at the dollar amounts, we can see that the trend is increasing. Healthcare per person spending is more expensive in 2019 than it was in 2013 across all lines of business. And because of this variation, so we can talk about percent increase, but when we start thinking about what this actually means, so how many people are enrolled in each of these markets, and that small change or that big change from the volatility on the previous graphs, what does that actually translate into dollar amounts, and what does that actually translate into in terms of the population? So there are some pretty big impacts of that volatility, and then there's also maybe lesser impacts of that when we think about the total spending and what that means for dollars. So again, similar, Medicare is per person dollar amount twice as high as the other markets. This is pretty comparable. Medicare is more expensive, we know that. But we just want to flag that difference and sort of switching gears or switching hats between looking at the percent change and understanding what's happening at sort of those high level trends, but then what does that actually mean in terms of dollars and budgets and what we're spending and how it scales.
The other thing that's curious to me here, Sarah, about these data And again, I'm the $10,000, 10,621 per capita for Medicare in 2019. That feels like that might be about right. But I'm not close enough to it. Craig or Bill would know. But what I'm curious about is the fact that commercial is below Medicaid. I mean, isn't the commercial fee schedule alone like 300 and 400% of Medicaid? Or, I mean, it's a lot higher. And now I know the benefit's not as rich, but I'm curious about from the plan folks, do those numbers look odd to you? Do you typically run lower per capita spend in your commercial book than you do in Medicaid, given the fee schedule differences? Any comments?
Populations would be younger and healthier than the Medicare population.
That is true. Then you mean, well, then Medicare, well, I fully expected Medicaid to be way below Medicare, Pat. I'm talking about between commercial and Medicaid. Maybe it's a younger population in Medicaid. It probably is, right?
Well, it's important to remember the ACA versus non-ACA. There's huge cost difference between the two. So ACA is
largely
healthier adults, but pre-ACA we had a large percentage of folks who were with large kids that were fairly cheap, but then one of the major eligibility categories was folks who were disabled, and the per capita spending on them is probably closer to what Medicare looks like.
And
self-insured's not in here, Sarah? Self-insured data
self-insured is not in here.
So that's also a big omission for the data.
Agreed. And I want to clarify that we're looking at per person. So the denominator for each of these lines here is the total enrollment. So if more folks are enrolled in commercial but are not receiving services, they're all in the denominator, but there's nothing in the numerator for the dollars spent on their services. So I think utilization is a factor here that we should probably also factor into the discussion, not just the price schedule or the benefits offered.
But I also think it's important to note that if all we're looking at is ACA and maybe small group and fully insured, those tend to be much lower benefits with a correspondingly lower per capita cost. If we're not including PEB and all the hospitals and all the big self-funded employers who tend to have richer benefits.
Sorry, PEB is in here. PEB and OEB are in here.
Oh, they are. Okay, good to know. All right, thank you. Interesting data.
Other questions, reactions, things that you think we should take a closer look at?
Hey, Sarah, this is Scott.
Go ahead, Scott.
My little CPA brain's about to explode thinking about this. Was there any change in payer reporting in 2017 or 18? Like, did Aetna come in, grab some market share, and then depart? Speaking hypothetically, I'm not trying to name someone specifically, but was there like either an addition or payers or departures of market share causing gaps?
I don't know that off the top of my head. I can check with the team, but does anybody else on the call know? We can look at that.
Other comments, folks? Anybody else? I'm curious to get some comment from Craig Anderson. Craig, you've been quiet. I know you're an actuary. So you have any actuarial insight here?
Not much more than what's been said. I think to really analyze, some of this looks strange, particularly the Medicare. And I think to get a better beat on that, I probably need to see some detail behind it. And your question about the Medicaid versus commercial also caused me to pause a bit about that. But I think for purposes, I'm trying to think of the purpose of these slides. I think, Sarah, you said this is the reason we're going directly to carriers, and that'll be the basis for our measurement. Are you just setting the stage for, I don't know, illustrating the costs have gone up over time? Is that, I'm just trying to think about how much we're going to rely on this.
That's pretty clear.
I think this is, we're trying to better understand and document what's been happening in Oregon historically. So whether that's costs going up, where the costs are going up, and then the next layer that we didn't present today, but that we're working on for the report is why. What were the drivers? What buckets of what service categories? Is it price versus utilization? How much variation are we seeing? What's the difference? What does that look like when you drill down by age, by gender, by geography? So really just providing a lot of that foundational information. I don't think we're asking for any new direction or action based on this. It's just to fill in gaps in our knowledge of what's been happening.
Is that to set a foundation for some of the work we're going to do around taking action?
Yes.
Okay. Yeah, I just am a little suspicious of this Medicare. I mean, I think we've said enough about that, but probably it's sufficient, the other market segments for that sort of work.
Sarah,
Lisa, can I ask Shannon, actually, she's a, I think that you have done, you are a broker and have, does this kind of track what your sort of change in plans have seen and like what you're sort of giving to consumers these days?
Because this is an average of everybody, it's kind of misleading. I think when you kind of see what consumers are actually experiencing, like I was thinking how our out-of-pocket amounts have changed in commercial plans over the same time frame. It was $63.50 and now it's $85.50. So for folks who take high-end prescriptions or have a lot of medical needs, this isn't going to be representative of what they're experiencing. I definitely think on the Medicaid line, we have a lot of folks who are continually enrolled but don't ever use it, right? So that's going to bring that number down, where on the commercial side in the individual market, you're probably not going to buy insurance very often if you don't need to use it. So that would be one way I would look at why that line's a little bit more expensive than the Medicaid side. But like deceptive, I think, from a consumer's perspective, based on how much the maximum out of pockets have grown over that same time frame.
That's helpful, Shannon. Thank you for that. Sarah, prescription drugs are in these data, right?
Correct.
So if you just do a quick per member per month kind of calculation on the commercial for 2019, it comes out at about $275 per member per month in 2019, including this prescription drug benefit. And Shannon, I'm just wondering,
And can I, sorry, Jack, I'm going to stop you there because I just want to make sure that we're being clear.
Yeah,
this is
please.
What's being spent on the claims for these members. This is not connected to what the members are paying in terms of premiums or out of pocket. This is what we see in the spending based on the utilization that occurred.
Right, but that does include the out-of-pocket spending that is paid to the provider by the member.
As represented by the allowed amount on the claim that we're using.
Got it. Okay. Yeah, no, I'm not, I don't care about premium. I'm just saying, I'm just curious to get some feedback. There's a $275 per member per month sort of cost. Sound accurate for a 2019 commercial product? That's what I'm just trying to get to, is if that's even helpful. If it's not, we can just ignore my ramblings. And that would be maybe the most important thing that we could do here. Does that resonate with anybody?
And again, this does not include the administrative costs or any of the non-claims based costs.
That's exactly right.
I can just speak for our health plan. I can just speak for our employee health plan. So we're a large group health plan. We have Kaiser Insurance, and we have for our staff, just to be clear. So we're a large group health plan for our staff, which I think trends a little bit younger, frankly, and is, I think a healthier population. So I will say it's healthier than the general population. It's younger than the general population, and our benefit is substantially richer than most commercial plans for our union staff. And that's about what it costs. I mean, it's, you know, it's a little bit more than that, frankly, but as Sarah pointed out, it doesn't include administrative stuff costs and some other component, but you know, it's within a $50 range per member per month of that.
Okay, that's helpful. Thank you. Looks like Bill has a hand up.
Yeah, and I mean, this is an offline issue, but more than willing, and it's sort of what Craig was saying for, I need to look at more data, but there is a phenomena with integrated delivery systems where we have medical expenses that don't hit claims data. So I know we've got some accommodations with the state on the APCD data. Don't know if that's the issue, but a chunk of cost time relatively significant market share could be driving these numbers a little bit lower than they should be.
And Bill, the team's going to correct me if I say this wrong, but I'm pretty sure. So as you mentioned, there is an arrangement with the state and Kaiser essentially submits claims that look like claims in a non-Kaiser, non-integrated setting, and that's what we're using here. So that shouldn't be an issue in this case, but thanks for noting the differences.
So Sarah, the weirdest thing to me in looking at these data, actually where the 19 data ends up does not look terribly askew. It's that $6,000 Medicare in 13 that then dramatically impacts the rate of increase over time. So I wonder if there's some reporting issue that goes back to the beginning of this that is more where the issue, if there is an issue, where it might be.
Yeah, that makes sense to me too, Ken.
I think we're hearing a lot of places that we should take a closer look and confirm potentially underlying data issues, or be very clear about what we're looking at and what's in, what's not. One question I have, maybe taking a step back, is when we think about the cost growth target program and the reporting that we plan to do for this program, we've been talking about it for the last 2 years at reporting at these different levels: state level, market level, by payer, and by provider organization. This is sort of the first time we've looked at anything by market. And I think based on a number of your comments, there's some not concerns, but I think almost hard to draw meaningful conclusions because it is all of the payers rolled up, and there is the possibility of so much variation across payers that how helpful is it really to look at the data by market? I would love any reflections on that. Or is it only helpful to look at the market if we also have the payer data to immediately drill into side by side? How does that land with you?
Thoughts, folks? By market, you're talking about these 4 markets or these 3 markets.
Yep, Medicaid, Medicare, and commercial.
I find the relativity very useful myself, but I can't, other comments, folks?
Well, this is Craig. I'm just now looking at another data source on commercial. I think that's too low. So Sarah, I wouldn't show this slide without some more vetting to any other audience. But to your general point about looking at it by markets, if we can clean up the data or use the payer data, which is ultimately what we're trying to do with the cost growth work that we're doing, I think that's very, very useful, because each market has unique things that are happening. Plus, populations move between markets with the economic factors. Commercial people go to Medicaid, for example, and we're aging as well. So I think those are trends that we should be monitoring when we're thinking about things over time. So I think market level is really important.
Thanks. I want to do a quick time check. I think we want to do public comment in a second, right, Jack? So maybe Bill has the last word on this topic.
And I was just going to chime in and agree with Craig. One, you got to look at it at the market level. And I would even suggest, because some of the dynamics, you need to pull ACA out separate from the other commercial. The other piece to, once again, just pile on what Craig was saying, especially since these are allowed trends, large group looks too low. There's just not enough dollars there. So.
Yeah, thank you, Bill. Sarah, we've got to probably wrap this up. Any other, you want to talk about next steps and where we go from here on this?
Yeah, thanks everyone for the
Please.
feedback. I think this was really helpful in giving us some additional direction and vetting, sort of a face validity vetting of this data. This is all preliminary. We'll keep digging on this. We are working on a report. We might bring it back. Some of you I might want to reach out to for some more specific conversations. If you're open to that, I would welcome maybe going a little deeper in reviewing this. But I think no action, no requests for the committee, but just thank you for your feedback and the time taking a look at this.
Thank you for presenting this. This was helpful. This is great. Okay. So where do we have any public comment? Has anybody identified? Have we identified anyone that we need to read anything or hear from somebody, Sarah?
Nobody has submitted anything in advance.
Okay.
So maybe if folks have public comments, if they want to raise their hand or indicate in the chat.
Okay, perfect. All righty. I don't see anything emerging yet. You want to give it a minute, or do we, I don't want to shortchange any citizen from saying anything, anywhere, anytime.
I'm not seeing anything. And I know that a couple of our committee members have a hard stop at 11. So maybe we wrap up a few minutes early.
Yeah, that's great. Okay. Thank you for any comments that you may have had in your head but didn't share. That's great. What do we, in terms of next steps, do we want to talk about our next meeting and what we can be thinking about for the November meeting? Okay, we have a time. Great. Are we going to try to, we're going to probably do that meeting virtually, or is there any chance? Yeah, it'll be a virtual meeting. We're not doing in person, even though it'll probably be our last meeting. I mean, couldn't we even have, like, I guess cocktails are not apropos. Got it. But I guess we'll just have to wish everybody well virtually, like we have been for 19 months or whatever it's been. Okay.
Hey, Jack, before you send everybody back, can I just add a reflection on the last conversation that we just had?
Please.
I was watching folks' body language and eyes twitching as they're looking at the data, as we have been trying to figure out what some of the anomalies are. And I do want us to not get be too dissuaded from it, because I do think, frankly, having the cost growth target is forcing us to then look at the data that we do have and use it in a different way and pressure test it and make sure that it's useful and that we're doing helpful things with it, as opposed to it just sitting in a database not being used. And so I think just like when we first started the cost growth target with CCOs, that then forced everybody to start taking the data more seriously and trying to understand what's going on the ground and pressure test it. And so would expect that that's a bit of the process we'll go through the next couple of years, and appreciate everybody bearing with us and providing feedback. But I do think that's kind of exactly what we want us to be able to start to do, is to be able to really use our data more effectively and frankly pressure test it and make sure that we're understanding what it's telling us about what's happening in the system.
That's very well said. It's a journey, not a race. Yep. Thank you, Jeremy. Sarah, can you give the committee a kind of a preview on what topics we're likely to be covering in November, please?
Ooh, pop quiz. I think we want to come back to the public hearing planning. I think we might touch on some additional data that we have for you, particularly the hospital price reporting that Jeremy mentioned. And we probably want to do a little wrap up reflection of our work and any setting the stage and guidance for the new committee.
Perfect. Okay, that sounds like a winner. We may not have 3 hours worth. If we don't, that's fine too. Yep. Okay, so are there any other additional comments that anybody on the committee would like to make before we send you back to your work and your families? Any thoughts? All right, well, hearing none, I want to once again thank everybody for their very thoughtful engagement here this morning. I thought the data was a great start, more to come on that, very helpful. And I want to just say thank you to everybody for all the great work, and wishing all well and stay healthy and have a, oh, no, we're meeting right before Thanksgiving, are we not? So we can wish people Thanksgiving then. Okay, wonderful. Well, just have a great week, folks. Thank you, Sarah and Jeremy and Michelle, for all the great work.
Great, thank you.